just want to introduce myself quickly. We had spoken before this. My name's Armand Ikagosi. I'm a functional medicine doc here in Henderson. I see children and adults. Practice focuses mainly on autism and autoimmune disease in adults,
okay,
as well as gut issues. This is Becky DeVilla.
Hi.
Hi. So you're in Henderson, Nevada?
Yes. Mm-hmm. Yeah, we're outside.
Excellent.
Mm-hmm.
Excellent.
So I have a child with autism. That's how I connected with Dr. Nick. And now I'm a holistic health practitioner. So I'm just wanting to learn some information that I can take back to share with other families in the autism biomedical community.
Happy to provide whatever information I can. MTHFR is important. I think you know that gluten is important. I think you talk about gluten with autism, yeah?
Yeah.
Right. That was one of the questions I actually had for you, because I was listening to one of your lectures yesterday, actually, where you were talking about the leaky mouth.
Right.
The gluten connection with that. So I think
right.
That's important information to share.
Well, yes. And, for 3 years, I don't know if you know Dr. Lisa Patera-Perry. She's also an IFM educator. And Lisa and I actually shared a practice for 3 years and saw patients together. And one of the most important things that came out of that time period was this link that we see between metal sensitivities, gluten, and MTHFR, methylation defects. And that if you have too much, have the third. And so where that translates into issues for kids is if they're going to have braces, because a lot of the appliances being used are nickel. And so that would be something to be particularly aware of. Or, you've got a child, and I'm talking perhaps more about the Asperger's kids, the more high, we have one of those in our family. We have a highly functioning, well, he's struggling dearly. He's in his 20s, Asperger's. It's my sister's son. And, it's difficult. But I think, you have to pay attention to what can go with that, with the gluten issues. So, yeah.
So in some of these kids, when they get the braces, that could be a trigger for decline, possibly, or
correct.
Oh, interesting.
Correct. There was a patient, Dr. Kenny Bach. I don't know if you know of Kenny. Kenny used to be on the IFM faculty. He has a large practice, mainly with children.
Dr. Bach. Yeah, he does a lot of Lyme treatment. I think he's from upstate New York, right? Yeah,
exactly. Great guy. He referred a patient to me because they can't do some of the testing, the ELISA testing. And he had a 16-year-old that wound up in his office, had been to lots, 12, 15 different medical centers. Moms had him at Mayo. It was one of these all-American kids. It's a case study that I reference in the lecture 2 of the IFM detox or environmental medicine program. But this child he was one of these all-American kids. He was a top student, top athlete, doing really well, and then all of a sudden crashed. And she had him at Mayo, she had him at Mount Sinai, she had him everywhere. And nobody could figure out what had happened to him and why his health had declined. And Kenny contacted me and said, I can't order a ELISA test for him. What can you do? So we set up a telephone conference, because they were in New York, set up a telephone conference. And this is when HDRI was in New Jersey. And so I was able to do a formal evaluation over the telephone, prescribe the ELISA test for him. Mom drove him down to New Jersey, got the ELISA test, and he was allergic to 9 different metals: nickel, molybdenum, mercury, on and on and on. And then when you go back through his functional medicine timeline, the braces went on. 6 months after his braces went on, he needed a tonsillectomy because he was having airway issues. And then, everything started from there. And so, his braces were taken off. I wasn't able to follow to see how he did, but his molybdenum reading was extraordinarily high. And molybdenum, I mean, this is, when I talked to the orthodontist had absolutely no idea molybdenum. They don't think about what are the metals in these appliances. Molybdenum is part of the mesh that's in the back of the orthodontic brackets that adhere the bracket to the tooth. So, anyway, there's very good studies that show there are titanium brackets. There's less children, I think, allergic to titanium than other metals. But, I think for kids with gluten sensitivity, the safest thing is to use ceramic brackets if they need brackets, or Invisalign. Now the problem with Invisalign, of course, is the plastics, right, in the trays. And we're actually having our patients use ClearCorrect because they're using Zendura. Zendura is a clear aligner tray that has a better chemical composition, I think, than the Invisalign trays.
Is Zendura what it's made of?
Zendura is the brand name of the product. Yeah. So we're using Zendura for all of our sensitive patients. If they need orthodontic, we don't even bother. Everything is Zendura. It's expensive, which is why Invisalign stopped using it. Invisalign changed their tray material a few years ago, and Zendura is expensive because no one else is manufacturing it. The patent is still valid on it, and it's proprietary. But if you've got something that's in your mouth 23 hours a day, and it's, the cost difference is maybe $20 a tray, at the end of the day, it's just not that much money.
So is Zendura just a different type of plastic polymer? It's
a different type of plastic polymer. Yeah, it doesn't have the isocyanates.
Okay, no isocyanates.
So for a parent that has a child with braces on, what are some of the first symptoms or signs that they might be intolerating the materials of the braces?
It's swollen gums. So I have a great photograph. And the person who put all this together was my hygienist, Jessica Cummings. She's taken AFMCP, and when her child is ill, go on and do the certification. However, so she came into work one day. It was during that period when Lisa was practicing, and she'd had terrible, terrible autoimmune issues. And she came into work and she said, "You know what I figured out?" She said, "I figured out my autoimmune issues never started until I had braces on." And at that point, we were using MELISA testing, which is a lymphocyte testing, and we can talk a little bit about material biocompatibility and materials testing, because there's a very important distinction to be made there. But anyway, so she came in and said, "Well, I noticed none of my autoimmune issues started." And I said, "Really?" She said, "No." She said, "I never had asthma. I never had hives. I never had skin lesions." At that point, she was in her late 20s. And I've known Jessica since she was 20 years old. She'll be 40 this year. She was in her late 20s at that point, and we had been able to do a little minor autohemotherapy and had been able to help with her seasonal allergies. But, the metals were still an issue. Anyway, we ran a MELISA test. Her reading for nickel was 35. It was just off the chart. And so it was when they put her braces on that she developed asthma. And it was exercise induced at the time, but that was the beginning of the cascade. And, she's then struggled with fatty liver and different things. But it was the trigger was when they put her braces on. So we had another child that came in, and he had braces just on. He was in his phase 1, where they line up just those 4 anterior teeth. And he had brackets on just his 4 anterior teeth, nothing on the lower, and was in having his teeth cleaned. And the orthodontist had been chastising him because, clearly, he wasn't brushing. And Jessica called me in. The gingiva, the gum tissue on his lower teeth looked perfect. absolutely perfect. She's no bleeding, no inflammation. She said, Mary Ellen, don't you think if this kid wasn't brushing, we'd see some gingival inflammation on the lower and not just puffy gums around the braces? Yeah. So I called the orthodontist, tried to get him to switch the kid out because I felt he was clearly showing signs of allergy to metal. Well, you know, they have their systems, right? And the problem with a lot of orthodontic offices is that the assistants do most of the tie-ins. And so when, you know, you have a system, all staff to use another system, it begins to be problematic. So anyway, when he finally got his full braces on with the same appliances, his tissues were just a mess, upper and lower. And it was at that point, Mom, he was older, you know, he was at the first time, I think he was about 8, and we didn't want to really do a blood test at that point. So we did a blood test then, and he, again, terrible, you know, 8, 9, 10. You know, we've seen people highly reactive to any and all kinds of metals. And so when I had the ELISA test, I was able to go back to the orthodontist at that point who made some changes. But so you could look for puffy gums. If their tonsils swell, right? If they start to, you know, if up until this point the tonsils, they had, you know, their tonsils were normal, but all of a sudden, like the kid that was referred by Dr. Bach, he needed a tonsillectomy shortly after his braces went on. And so that would be a clue. Hives would be a clue. Rashes around the mouth would be a clue. So there's a few things where you could begin to think that the metals may be an issue. But we just see this reactivity over and over and over again. And now it's so easy, you know, these kids, it's so easy to test for MTHFR and COMT because it's a salivary test. So if you know the child is gluten sensitive and you're seeing different polymorphisms with your B vitamin metabolism, then I think that that's a child where I would have, we counsel the children in our office to clearly avoid metal braces.
Would this be the same case for spacers in children? Is it the same kind of metals and materials used?
It is. It's got nickel. You know, the spacers have nickel. They do. Those, you know, that's the conundrum with kids, you know, so you don't necessarily want to do a pediatric root canal. So you take the tooth out and then they put in the space maintainers. But the space maintainers are often made of stainless steel, and stainless steel has nickel. So that's the conundrum.
Is there some like a Zendura type of spacer or? Well,
you know, you could, you know, then it gets tricky. I mean, you could make another really good plastic is the plastic that they use in. I'm drawing a blank on it. I can't. It's for retainers. We use it for flippers, for false teeth. It'll come to me. But Zendura is a clear plastic aligner, and the problem is that if the child is growing, it's going to have to be changed out. But you know, you could do that. I don't know. My daughter actually works in an orthodontic office. There might be titanium options for spacers. So I think the reasonable request from the parent would be to please not use stainless steel in my child's mouth. And the orthodontist may need to do a little bit of work to educate themselves, because oftentimes they don't know. You know, they don't know the full extent of what they're using. You know, maybe they could put 2 ceramic brackets with a little wire between to try to maintain the space.
Or would it be better in some cases to just do no spacer at all? Or how bad would that be for the new teeth coming in?
Well, it's, you know, it would really mean that they would have to have braces. So, I think the big thing is to just try to find a more biocompatible way to deal with it. And try to get them to use titanium. I mean, that's, titanium or ceramic.
When you do the ELISA testing, what lab do you like to use?
So we're using the lab in Switzerland because we don't have a ELISA lab at this point in the U.S. I know that Marty Costello for IFM, because it was a bit onerous, frankly, trying to set that up. Dr. Ray, who's terrific. I love the lab. I really do love the lab. He's now using that LTT testing, ELISA testing, to test plastics, which is why I use that specific lab. I can pull the name up for you out of my email. But he will test plastics, BPA, BPS, Tegma. He's also testing different food substances as well. So he's using the ELISA test to test a variety of things, not just metals. And that's what makes his lab unique over ELISA labs in England and Germany. So that's specifically why now, I'm getting things coming up where Zoom can't detect your microphone and Zoom. Are you hearing me fine?
Yeah, yeah, we hear you great. Yeah.
Okay, good.
Just a temperamental computer.
Yeah.
We got a proper introduction of you and your practice and what exactly functional dentistry is. If you could explain a little bit about that for our...
I will. So my name, I'm Dr. Mary Ellen Chalmers. I am a certified functional medicine practitioner, have been certified since one of the early cohorts in 2014. My first lecture given for the Institute for Functional Medicine was back in 2010 when I lectured in the cancer AIC and lectured in integrating dentistry into cancer prevention. My background is I got my dental degree at Tufts. I had a pretty routine general practice until the mid-1990s. I stopped as soon as we got a really good composite resin material that we were able to place in posterior teeth. I stopped. I haven't placed mercury now for over 35 years. I mean, 1987, I think, is when I stopped placing mercury amalgam. But when I was in 1995, I was in a serious auto accident when I was pregnant with my second child and had to stop practicing. Had some significant injuries, had to stop practicing. And fortunately, my primary care provider was one of Jeff Bland's early students, and it was functional medicine that, because at that point I'd been hanging around mercury. Even though I wasn't placing it, I was taking it out. And so we did a lot of detox, and because I had a head injury, carpal tunnel, all kinds of musculoskeletal, fibromyalgia, was not better 2 years after the accident. And it was functional medicine that made the difference. So when in 2000, when I was able to go back to work, I determined that I was going to learn more about this wonderful modality that had saved a profession for me that I loved. So I, for years, was the only dentist in the room, and got my education through the nutraceutical trainings. That's how I met Lisa, because I would attend a lot of her presentations with Metagenics. And when I could understand 75% of what Jeff Bland had to say in a lecture in 2008, I felt like I was ready to take AFMCP, because he would give those annual lectures for Metagenics. But yeah, when I could understand 75% of it, I thought, okay.
75% comprehension with a Bland lecture is pretty darn good, though. So yeah.
Oh, but it took me years to get there. And so I started my certification training, and at the same time enrolled in a dental naturopathic program. American College of Integrative Medicine and Dentistry has a naturopathic program for dentists. It's a 2-year program where we earn an NMD, and it's a wonderful program. So from there, I then migrated into the certification lectures. It really gave me the background I needed. I think the certification classes were great for, MDs, DOs, PAs, NPs, but, Tufts had more medicine than most schools, but it was still, it was challenging. I feel like I kind of went to medical school going through those, the certification classes. It's not easy. Anyway, so what's evolved was functional dentistry, because what made me comfortable, I had a biological practice, but I was never quite comfortable with some of the absolutes, that all root canals were bad. And I have never had any disagreement about mercury. I mean, the mercury just doesn't belong in our head, period. What sense does it make to store a heavy metal in our head? I had a patient say that to me in 1987, and that's when the light went up, finally went on. That and the fact that I had a restorative material that I could use. But what functional dentistry does, and I think functional medicine really brings a depth and a dimension to biological dentistry, in that we're able to address and diagnose and address problems. Using the functional medicine model, we are able to individualize and personalize care and make different decisions in a way that perhaps, with different skills than a standard biological dentist would. So, for example, again, everybody, I don't think anybody should have an amalgam in their mouth, but, finances being what they are, a lot of patients can't afford it. But when we look functionally, Mark Houston has a wonderful article on mercury and how it affects the endothelium. That was published in the Journal of Hypertension, I believe, in 2011. And so, if we see people with hypertension, cardiovascular disease, those are someone that we're going to have the conversation about the effect that mercury has on their endothelium, to encourage them, to them why it may be especially important for them to get the mercury out. Another area is periodontal disease. We're doing a lot of culturing and identifying the pathogens, because we now know that the pathogens, particularly P. gingivalis, Fusobacterium nucleatum, Treponema denticolica, Tenerella forsythia, and the one that we abbreviate AA, I can't pronounce it, won't try to pronounce it, but we do know the roles that plays in dementia, in cancer, cardiovascular disease. So having a better understanding of where the functional medical challenges are for a patient, it gives me a direction to look for how to tailor their dentistry. I think it's critically important. There was an article published recently, was an editorial in the Journal of the American Dental Association, published by the editor, Dr. Michael Glick, who is a former dean of the University of Buffalo School of Dentistry. And he referenced the fact that he is concerned about the profession because up until now, we really don't have a foothold in the direction that medicine is taking with individualized, personalized care. Because so much of standard American dentistry is one size fits all. Everybody gets a composite. Everybody, there really isn't. There isn't the acknowledgement that patients have different issues. Your cancer patient is going to have different needs than your autoimmune patient, and so by incorporating systems biology and functional medicine into the diagnosis, we can really begin to have a much more significant place in that conversation in a patient's health, because the oral cavity it's foundational. It's critically important. And
how do the diagnostics differ between functional dentistry and your standard biological dentistry?
So the first thing we do is I take a history based on the timeline. So if patients come into me saying, I felt sick, I was doing great until, we try to find out and tease out what could have happened. We hear a lot. I was fine until I had my root canal done, or I was fine. Mercury amalgams were taken out, and they were taken out without precautions. We oftentimes will see patients with diabetics that are having issues with blood sugar control. And so, again, we'll be treating their periodontal disease, but we treat the periodontal disease along with identifying what those pathogens are. It isn't just a matter of going in and doing the physical probings and the physical cleanings. You really need to understand what the microbiome is. And we're going to use special testing to assess the microbiome. In my office, I use something called an oral potential meter. It will measure galvanic activity and tell me whether I have a battery in a patient's mouth from different metals. That we use strictly for patients with metal in their mouths. A lot of patients who don't have any metal don't need to worry about that. But very often we'll see a mercury amalgam next to a gold crown, and that's a source for the battery. And the significance of the battery is when you have a battery, when you have an exchange of electrons and ions as a result of different metals, the metal ions generated, again, then get absorbed into the body and have the potential to create autoimmune issues. We use something called the Velscope in our office, which is a screening tool for oral cancer.
You said Velscope?
Velscope, VELSCOPE. It's a light that we shine on the oral tissues, and it interacts with cells called fluorophores below the surface of the oral epithelium. Those fluorophores, when they're healthy, reflect the light back in a certain manner. If they weren't healthy because of changes in function, the cellular function is going to alter with cancer patients. And so the fluorophores aren't activated, and we would see a black area. And so why we use that is because 60% of all oral cancers are not diagnosed until stage 3 or stage 4, because we're waiting for the tumors to show up on the surface. We hope that by identifying changes in cellular function underneath the surface, we can catch things sooner. So that's a different thing. But I think the big changes are, number one, that the history. What my functional medicine training has taught me is how to take a history with the timeline in mind. Then thinking more in a systems biology, from a systems biology paradigm, the functional medicine matrix. So that kind of sets the stage. And then, I probe every patient. We check for caries. We do all of the standard things. But for example, if I have a patient with a lot of bleeding and inflammation, we're going to use an oral DNA test to take a look and see if the microbiome has been altered. If I have a patient with a lot of bone disease, we're going to check their vitamin D levels. Patients who need periodontal therapy, patients who need endodontic therapy, patients who have high decay rates. In children, particularly with high decay rates, it's important to take a look at the vitamin D levels. The literature is really quite clear that it needs to be 50 nanograms per ml or above. And the other thing I see very often is patients may be taking D, but they're not taking K2. And K2 is critically important. And K2 is missing a lot, actually, in patients with high decay rates. So, it's a lot. It's very similar to a standard dental exam with a few add-ons, I think, that make a critical difference.
One of the things that you mentioned that you look for is for pathogens in the mouth. So when you come across different pathogens, what kind of treatments do you use to fight those? So
it depends on the pathogens, and it depends on the extent of the pathogens. The 4 most virulent, and I actually do include a fifth. It's our P. gingivalis, Treponema denticolica, Panarellia forsythia, and it's AA. And I can't print. It's Actinobacter, actinomycins. It's referred to in the AA is how it's abbreviated. Those are really the four most virulent pathogens. And I also add in Fusobacterium nucleatum because as I read the literature, I see that implicated a lot, particularly in cancer and dementia. So depending on if they have any of the big four, we are going to think about long and hard about antibiotic therapy. And the reason is that these pathogens burrow into the tissues. And so if you can scale and root plane and clean the teeth all you want, but if you've got pathogens that are burrowed in tissues, unless you really treat those pathogens with antibiotics, you're not going to eradicate the infection, eradicate the problem. So we get really good results if we have a patient with active periodontal disease, we will do the scaling and root planing, but we do it in the presence of the appropriate antibiotic therapy, where the pathogens are being specific regimens or regimens, antibiotic regimens are for specific pathogens and the level of what those pathogens are. So the antibiotic therapy is customized. We use a laser, and we also use ozone. We use ozone water. Every patient every day is cleaned with ozone water. We've seen dramatic decreases. It's in our Cavitron. We don't have our piezo unit. We don't use a Cavitron. We use a piezo unit, which has a different wave shape for an ultrasonic scaler. And the water that we use with the ultrasonic scaling is always ozonated water. We'll use differing concentrations of ozonated gas around the pockets of certain periodontal. Patient has a periodontal lesion, and what we also use with all patients with pathogens and is a laser, a diode laser. So we finish with a diode laser.
Have you noticed a recurrence rate with some of these pathogens? I know when I treat the gut, a lot of patients. Some patients it's great. You do a reset, they do wonderful. But we have some that kind of no matter what we do, they just seem to come back. Do you ever run into those sort of issues with the oral pathogens?
We do. I mean, the gut and the mouth are linked, and so if we are experiencing all the same tube. So I can imagine if you've got if no one is properly and thoroughly evaluating their oral microbiome, you swallow 1 trillion bacteria a day. It's going to have a direct impact on the gut microbiome. Another problem is mercury amalgam. I mean, if they have mercury fillings, we know. I mean, there's several articles in the literature that document, and they're mouse studies. They're not human studies, but it documents the alteration in the gut microbiome from the off-gassing from mercury. So there's a lot of interplay between the oral cavity and the gut. And I don't know how anybody practices without the oral DNA test, because unless you know what the pathogens are, it's very difficult to really address the disease and have it actually stop. We had a very interesting case, though. We had a woman that was referred in. She, early 40s, was having dramatic horizontal bone loss. And so we did our standard thing. We probed her. Her home care was impeccable. Very few pockets, but they were just watching her bone just shrink. So we did followed our procedures. We charted the pockets. She was inflamed. The tissues were inflamed even though there weren't pockets. Her home care was exceptional. There was no plaque anywhere to be seen. We got the oral DNA back, no pathogens. Absolutely none. So we tested her for gluten sensitivity, and sure enough, she was a celiac. So, and when she went back to her dentist down on the peninsula, they were incredulous. Well, we've never heard that. Well, I mean, we did the genetic test. Her anti-gliadin antibodies were elevated. Her tissue transcontaminase antibodies were elevated. And it was just a different, atypical manifestation of celiac disease and gluten sensitivity. So it's important to recognize that as well. And so again, when you ask about different diagnostic tools for functional dentistry, that's one of the things we use all the time. Yeah.
Could I put, there's a kind of common clinical dental scenario a lot of my patients kind of run into with their autistic kids. And I just kind of wanted to throw it out just to get your viewpoint on it. So a lot of the kids on the spectrum, in the course of their childhood or their regression or whatnot, there typically is some form of surgery, possibly anesthesia involved, and commonly we'll see a regression after this. They'll say, oh, the kid got the tubes in his ears, and after the surgery, it just never was the same. He lost the speech, lost this, lost that. So there's a lot of apprehension about possibly reacting to some of these anesthetic agents. Then we couple that with a lot of autistic kids. It's hard to get good, home dental hygiene on them. They kind of don't let you. So a lot of them have cavities. A lot of them have bad teeth, so to speak. So invariably, you're going to have cavities. They're 4 or 5 years old at some point. And most of them won't be cooperative. So, you have to kind of put them out for them, sedate them or put them under general. So in this scenario, obviously, if the child's in pain, I think you got to kind of do what you got to do. But in a lot of the situations, they won't necessarily be in pain or they're not sure. And the question, a lot of the parents, they'll pose it to me. And of course, I'll say, I'm not a dentist. I don't know. But, their concern is, can they just sort of let it go? Because they're sort of terrified of giving the kid the anesthetic agents because of their prior experience.
Right. Right.
And how would your approach to a situation like that be, where the child is relatively asymptomatic and maybe not necessarily in pain from it, but there's that cavity there, it's in a baby tooth, but the parents are really afraid to put them under?
So first of all, any child where you suspect MTHFR should never, ever have a nitrous oxide. Mm-hmm. Are you familiar with the literature on that, right? Mm-hmm. There's some speakers out there that are saying, well, you just treat them with B vitamins and, make up for it that way. And, for a child that's compromised, I don't even think I'd take that risk. There is something called silver diamine fluoride. And, fluoride's a nasty word. Fluoride, we think of fluoride in my practice as chemotherapy. We have not eliminated it topically. I use it cancer patients, xerostomach patients, where we can't get a hold. We just can't stop the decay using everything else, and we can talk about what some of the other ways of remineralizing teeth are. But silver, we do know that fluoride. There was an article published. The scientific report is published by Nature, and there was a article published on the effect of fluoride on TSH levels and thyroid function, having an adverse effect. But silver, I think, so I acknowledge the issues with fluoride. I don't think fluoride belongs in our water. I'm opposed to fluoridated water unequivocally. But silver diamine fluoride is something that you can paint on the tooth. It will turn the tooth black, which is really not an issue for a baby tooth that they're going to lose. And it will arrest the decay. Okay. And it arrests it, it stops it in its tracks. And I think, when you consider benefit risk, everything, you just have to weigh the risks versus the benefits. And if you can put the silver diamine fluoride on with a rubber dam, again, that might be difficult with an autistic child or, with lots of isolation, and arrest the decay, particularly in a primary tooth. You could even do it, strategically in an adult tooth. Again, know that it's going to turn the tooth black, but if it's a posterior tooth and you can't get back there, perhaps until dental work can be completed.
And some of the risks of doing nothing would be the decay possibly going into the root and possibly affecting the permanent tooth, right?
Correct. Yeah. I mean, so doing nothing in a primary tooth, I don't often see, if a primary tooth abscesses, I rarely do we see it actually affect the permanent tooth. Of course, if they lose the primary tooth, then, we have spacing issues and crowding issues and all of that. But for, for a permanent tooth, you want to arrest that decay because you don't want the decay to go to the nerve and have a root canal. I mean, if that can be avoided, that would be an important thing.
So if anesthesia is needed, what would you recommend as the safest option for those with the MTHFR mutation?
If they have an MTHFR mutation, I would also encourage looking at their cytochrome P450 genetics for liver detox, the liver pathways, the cytochrome P450 pathways. And, anesthesiologists can really customize the delivery of anesthesia depending on what the cytochrome P450 genetics are. So, again, there's we now do our MTHFR/COMT/gluten testing with functional genomic analysis. And in that same panel, that $199 panel, you also get the full complement of CYP450 genetics. So if you know in advance, if they have a 2D6 polymorphism or a CA4, CYP3A4 polymorphism, the 3A4 polymorphism, you're going to want to customize the anesthetics based on that. And from my personal experience, I've used that recently with anesthesiologists, and the anesthesiologists that I've dealt with have been able to do a really excellent job.
So the challenge would be finding an anesthesiologist who will sort of personalize that cocktail for the child. That would probably be the
yeah. Yes, though they're out there. I had breast cancer surgery 5 years ago, and just spoke very directly to my surgeon, saying I need my mother had a history of nausea and terrible headaches following anesthesia, terrible reactions. And I told him, I said, I know my cytochrome P450 genetics, and I want an anesthesiologist who's going to be able to work with that. And his eyes got like saucers. He knew he didn't know, but he knew he should know. I mean, I think a lot of the MDs know that they should know what we're talking about. And I ended up with the head of anesthesia for CPMC, and he was amazing. He was absolutely amazing. I woke up after 10 hours of general anesthesia, just clear as a bell. And most recently, just had a little foot surgery, and said the same thing to the anesthesiologist. So I think it's getting easier. The two anesthesiologists I saw most recently, they knew exactly what to do. My problem is I have 2D6 polymorphisms, and so they need to stay away from anything fentanyl, anything like that that's metabolized on that pathway. So I think it's critically important for these children to know what the cytochrome P450 pathway problems are, and the anesthesia can be handled that way.
And if they don't know, then they should take your environmental medicine lecture, which goes over all that stuff. So
exactly. And for a parent, if you've got an anesthesiologist treating your child in this day and age that doesn't understand cytochrome P450 genetics, find a different anesthesiologist. I mean, because I've had wonderful experiences, and they know. I mean, they know. I think so.
Well, the knowledge has been out there, but 20, 30 years. I mean,
Yeah.
It's a matter of applying it. So.
Yeah, exactly.
So if the genetic testing wasn't an option beforehand, is there a anesthesia that's generally pretty safe for everybody? I think I've seen, I don't know if I'll say this correctly, sevoflurane.
Yep. So.
Sevoflurane as being recommended.
I don't feel comfortable to recommend for kids. I'm certified in oral conscious sedation, but adult oral conscious sedation. So when we had, I'm not current on that.
Can I ask you this though? I guess what determines if you do oral conscious sedation versus a general anesthesia? Is it more like the length of the procedure, or how painful it could be? I guess what sort of factors go into that when you decide?
Well, with the adult patient, if it has to do with the amount of dentistry being done, it has to do with the fear level. With children, you're talking about management. So it is different. The other issue that we're seeing in dentistry, and it's really very controversial, so if you're talking about dental issues, it's the issue that, in dentistry, we have oral surgeons, and again, I'm talking about, well, I guess this whole conversation's been kind of controversial. My profession the oral surgeons aren't going to appreciate the next few comments. But, in medicine, it would be unthinkable for a practitioner to be delivering the anesthesia and be providing the surgery. In medicine, you have an anesthesiologist and you have your surgeon, and each is responsible for managing the patient in their scope. The issue that I see with dentistry, and I think it's a valid one, this is being raised and the oral surgeons are pushing back hard, and I think it's especially important for children, that very often you have an oral surgeon who's managing the anesthesia at the same time as they're treating the child. And I do believe that I think dentistry should practice at the same standard as medicine. And I think that...
Right? Just because it's on the mouth, it's no different than doing surgery anywhere else.
Correct. And we do have dental-specific anesthesiologists. Now, it's again, it's more expensive, right? Because you're paying for 2 practitioners versus 1 practitioner. But if you're talking general anesthesia or you're talking IV sedation, if it were my child, I would want my child to have someone focusing on their sedation and not focus, and someone else doing the procedure. Oral conscious sedation, what we do in our office is different in the sense that the patient is always able to respond. And if we get to a point where a patient isn't able to respond, then we stop the procedure and focus on the sedation and call the appropriate people or take the reversal. We reverse the medications. So, with these autistic kids, I think having an anesthesiologist familiar with their cytochrome P450 genetics, handling the anesthesia separate and apart from the practitioner who's treating their mouth. Yeah, I think we need to assume that, as I said, we need to assume the same standard that medicine uses.
So what is your favorite toothpaste, or what do you recommend for your patients?
So we use in our office we stock the tooth and gum paste. That's our dental herb company tooth and gum paste. Not for children. It has an acquired taste, and I have some adults that won't adapt to it, but it's a great herbal toothpaste. There's a new product out there called the Dirt. It's actually manufactured here in Santa Rosa. She's a chocolate mint. It's all, she's got some great flavors for kids, and it's coconut oil based, organic products. It's a wonderful, wonderful toothpaste. Another one for kids is Jason's. And the problem is the Jasons, and I can't remember now who they were recently acquired by, but we used to recommend Burt's Bees a lot. But Burt's Bees was acquired by, I think, Clorox or P&G. Anyway, but the Tom's of Maine. Tom's of Maine is no longer as compounded as well, since they were acquired. Is it Procter & Gamble acquired one, Clorox acquired another.
One of the international marketing companies.
Yeah. So the dirt is on Amazon. That's a great company. And again, we love the tooth and gum paste. I've been using that for years. And it's important when they take a look at tooth products that they keep no sodium lauryl sulfates. I think the sulfates are what needs to, again, this is where fluoride, the fluoride conversation gets tricky. Because if you've got children where hygiene is an issue, you certainly don't want to see the teeth decay. The other thing we use all the time for children is something called MI paste. It's amorphous calcium phosphate. Studies on amorphous calcium phosphate show improved remineralization of the teeth, even better than that of fluoride. And so MI paste, what I don't like about MI paste is that it has propylene glycol, which I'm not wild about that, but I think propylene glycol is better than fluoride. So we use a lot of MI paste. We'll have the kids use the MI paste when they brush at night rather than toothpaste.
Safe if the child's unable to spit it out. So if it is swallowed, that would.
Yeah, exactly. Yeah. Otherwise, they could be ingesting too much fluoride, and that's not a good thing.
And what about the use of dental probiotics? Do you find those helpful?
I do, not as helpful. So I know there was a company that had a product called, it was a strep salivarius based product. I think it was Probiomax DDS. And I had that in the office for several years, and we just didn't see the results. I do think probiotics are great for oral inflammation. For gingival inflammation, we see dramatic results. And we've just told people to, the probiotic powder. We get the Clara Therabiotic and just dip the toothbrush in and brush with probiotic powder and then swallow it. So they don't need, you could get the special dental probiotics, but we've had great results using just a traditional, really good probiotic, and you putting that on your toothbrush, brushing with it, and then swallowing.
And I know we had discussed quite a bit about the silver amalgam fillings. Can you share a little bit more about what kind of precautions are taken during proper removal and why it's so important to follow those? Right.
So I would direct the public to the IAOMT, www.iaomt.org. What specifically the SMART, S-M-A-R-T, amalgam removal protocols. In our office, we have HEPA filtration. There's a HEPA filter that sits right here when the amalgams are being taken out. The patients are draped. They have a supplemental oxygen source. Always use a rubber dam. But we drape them head to toe. Their hair is covered, their face is covered. It's just basically here, because there was a study published last year where the aerosols from the mercury really do go everywhere. So it's important to protect their clothing and to capture as much of that as you can. So rubber dam, specialized suction tip called the cleanup, which kind of envelops the tooth. And then, as I said, the big HEPA filter, HEPA filtration here. But the protocols are elucidated with SMART. I'm sorry, what were you going to say?
Sorry. Do you protect yourself with a respirator?
Absolutely.
Right.
Yeah, we have a respirator. We wear a respirator, disposable clothing, hair nets. Yeah.
What kind of negative side effects could someone see following the removal if they don't follow these precautions?
And that's hard, and it's individual, and and sometimes the side effects can show up delayed. It could be anything from compromises in immune function to headaches to brain fog it's really going to be based on a patient's individual genetics, and this is what makes the whole topic so difficult, is that the symptoms are somewhat nebulous. They're definitely present, but it's so different with every individual that it's difficult to pinpoint. Yeah.
I know your specialty is not pediatrics, but I'm curious if you are familiar with tongue or lip ties and if those play a role in tooth decay.
Well, they do. And particularly, there was at the IOMT website, Robin Abramczyk just did a wonderful scientific paper on tongue-tied and clipping the lingual frenum, and how with failure to thrive and breastfeeding. But yeah, it does make it's an important thing to screen for.
Okay.
Yeah, she's got a great paper at the IOMT website about that.
Do you have any thoughts on oil pulling?
I've been doing that.
So, Deanna Minnick and I always get into this. It's like an annual thing when we're at detox, and there's nothing wrong with oil pilling. It cannot take the place of physical biofilm disruption. And again, this is a wonderful visual from our hygienist, Jessica. Jess says, your dog bowl, there's a slime sometimes that develops in the bottom of the dog's water bowl. Well, that's a biofilm. She said biofilms are what we also have in the mouth. So if you're going to clean that dog's bowl, the water bowl, are you going to put some oil in there, swish it around and tap it out, or are you going to get in and scrub? So do we see people have less inflammation from oil pulling? Yes. Is there, you have to go to the Ayurvedic literature to find any kind of research on it, because there isn't anything in anything other than the Ayurvedic literature that I've seen to support oil pulling. What I've seen is, I think someone recently I read recommended 5 minutes. Some people, I don't even know how they're oil pulling for 20 minutes. I can't imagine oil pulling for 20 minutes. I read somewhere that they thought 5 minutes, maybe it was Mercola, where they recommended 5 minutes would be adequate. I have no reason to not do it. It isn't something we recommend to our patients, because we're already asking them to spend a minimum of 2 minutes twice a day, of the full 2 minutes brushing their teeth and flossing, or using whatever they need to do. There's a lot of different tools out there to get into proximally we call it biofilm disruption. And so to ask them to oil pull on top of it. I have some that do it and their tissues look great. So I'm not opposed to it. It cannot take the place of the actual physical tools that are needed to disrupt the biofilm.
Do you think the antimicrobial properties of coconut oil could reduce the pathogenic load in the mouth?
I haven't seen a study on that. I can talk about the physical evidence. We see less inflammation. We see less gingival inflammation. We do. But we also see less gingival inflammation when people are diligent with brushing and flossing.
Right.
So, yeah.
Could you walk us through like a daily regimen that you would recommend to one of your patients for optimal oral health?
So we're a big believer in electric toothbrushes.
Okay.
And I think that would be especially important for your autistic kids because manual dexterity is hard. In our office, we do prefer the Oral-B small round head. We tell their patients when they buy the Oral-B toothbrush at Costco or Target or Walmart, throw away the head that it comes with and buy the extra sensitive heads that are sold separately. And it's small. They're small. The bristles are very soft, and they do a really, really good job cleaning. We're not opposed to the sonic care. I think the sonic care sometimes can be a bit aggressive, and the Oral-B might be a little bit more tolerable for these kids because they're so sensitive. So the first thing is to make sure that you can, the electric toothbrush, full 2 minutes. And then I personally floss. I can floss. Some people can't get through their contacts. The in between the teeth is too tight. The one thing that I do want patients to stay away from is Glide. Glide has got Teflon. So unless you want to floss your teeth with Teflon, because we don't cook with Teflon, we're not recommending people cook with Teflon anymore. So Glide has got Teflon, so we're advising patients to stay away from Glide. Oral-B has a satin floss that is not coated, that isn't a Teflon-based product. There's waxed floss. There's all kinds of floss. The other little trick that we have, and for patients who aren't wild about flossing, I believe it's a Butler product. I call them the little green guys. I should have had the aids here to have shown you, but they're a little green tip. Costco has them. All the Rite Aid, Walgreens, CVS, but they're a little green, like a tiny little Christmas tree, and they'll go right in. There are very few embrasures that I can get in, that a patient can get in, and sometimes patients will say, "Wow, I think that feels better for me than floss." So that just needs to be done once a day. For patients who have a tough time with the interproximal, and you're really, yes, you're removing plaque, but really what you're doing, you're focusing on the disruption of the biofilm. It's when those bacteria organize that they become pathogenic. So yeah, you're going to get plaque out, but I think we're talking more about biofilm disruption than we are about actual plaque removal. So I will say to patients, floss or use your interdental picks first. Try it in the morning. I know sometimes at night I can find, if I'm tired, I can find all kinds of excuses to not floss. It seems easier in the morning. One of the tricks that did it for me was the studies on longevity. People who disrupt that interproximal biofilm are going to live on average 7 years longer. And I was an old mom. I had my kids at 38 and 40, so my kids have told me I have to stick around a long time.
7 years, wow.
7 years. Yeah, that study was early 2000s. That study came out.
That's a great idea for flossing in the morning, because I'm in the same boat with you. I got about 101 excuses at night to not floss, so it's pretty easy to come up with.
Not a morning person though. What about water picks? Do you find those helpful?
I think, for people who have bridges or implants or big spaces or embrasures, yeah, water picks are great. And the Dental Herb Company has a tonic that you can put in there if you've got periodontal issues or have issues with pathogens that we work really well. It's not alcohol based. That's another important thing with your oral health products is they have to be alcohol free.
Okay.
Because alcohol dries out the mouth. And one of the most important protective things we have for decay and for oral health is our saliva. I think we're just beginning to scratch the surface on understanding how saliva is different for everybody. Every patient has different saliva. And it's just so important. I think the role that it plays in our gut. I don't even think we've begun to understand that. I mean, predigestion starts in the mouth. And so what are those, how do those, when I really want to nerd out, I'm getting a master's at USC in oral medicine and oral facial pain. And, but one of my fun things to read is saliva and all the different things that we're finding out about saliva. If I really want to geek out, that's kind of, where I where I go, because I think it's fascinating to me, and I don't think we've quite appreciated or understood the full dimension that it has on our health.
And
I think a peripheral aspect for better dental health also would be ensuring that the child or adult is not mouth breathing during sleep.
Yes.
That'll dry out the mouth significantly.
Yes, that's true. And so there's a new movement called mouth taping.
Yep.
And I was just given a really good article on that yesterday and haven't had a chance to read it. I have a close friend, periodontist, that I work with, Dr. Christine Ford, who is a big advocate of mouth taping. There was a lecture given at IAOMT a couple sessions ago on mouth taping, and I apologize, I'm just not current on it, but I would encourage people to take a look at that. There's special tapes now that you can use that don't irritate the skin. I would think paper-based tapes. I haven't had the guts to try it myself yet. Just the thought of it.
I actually did it with my oldest son about a year ago. Yeah, and it actually worked quite well. He had a lot of sinus issues and allergies when he was younger, and his sinuses were congested. I did it for about a week, and that's all it took, was because it became a behavioral thing. We have done a lot of work to clear his sinuses and get them so they could pass air through it. So that goes without saying. You got to get the sinuses open.
Right.
But there is a behavioral aspect where just the kid's sort of used to it because that's what he's done his whole life.
Right.
And sometimes just getting a week of sort of retraining that behavior can be all that it takes. I wanted to stress one thing. I think it's important. Make sure if you're doing it with a kid that they can communicate to you to tell you that they can't breathe or they're
right.
uncomfortable or something like that. If they can't do that, you want to be really careful with that because you need that feedback from the kid.
I'd be worried they go to school and be telling people like, "Oh, my mom tapes my mouth shut."
Yeah.
CPS knocking at the door.
Give them a good cover.
Yeah. I think, sleep apnea is a big deal. And now I think that as we talk about that a little bit, I know that there are practitioners saying that everybody who bruxes has got sleep apnea. And that's a bit of an overstatement. The literature that I've seen shows that it's about 25%. So it's certainly something that I think needs to be considered. If you've got a child or an adult that's grinding and bruxing, are they snoring? I mean, that's the question I ask when the first question I ask when I notice that someone appears to have physical symptoms in their mouth that they're grinding. The next question is, do you snore? And so identifying apnea and treating apnea is important.
Do you think that parasites could be playing a role in the bruxism as well? Because I have read some studies on that.
Parasites?
Mm-hmm.
I'm not familiar with that, but boy, I'll take a look at that. I don't know. I don't know. It's fascinating. Wouldn't that be nice? I mean, it would be easier. There is a device being developed in Japan that is supposed to do basically a low-level electrical stimulation to stop the bruxism without waking patients up. And the initial studies that are being done with that have shown that it's really effective. But we don't have it yet in this company. There's another device, I think, being developed in Germany. No one seems to be working on it in this company because of the patent issue, right? It's really not something that can be patented, and but I'm anxious to have one of those. I think it'd be a great alternative to night guards. I mean, you're working.
Is that electrical stimulation that they do on the mouth?
Yeah. Just very low level, but they're finding that it's having a really positive effect in stopping the grinding.
It's interesting.
Yeah. Relatively new study that was published. The head of our oral facial pain program at USC was one of the authors on the paper.
Now, I heard, speaking with other dentists, when I asked them what's the best material to put for fillings, what I got back from several was gold. Just good old-fashioned gold. Do you agree with that?
Well, that's what I restored my mouth with.
Right.
When I took my amalgam, because, well,
okay.
you know, I mean, I have metal bisulfide issues with the preservatives in the anesthetic. I'm a terrible patient. And, you know, David Biles in Santa Cruz I took them all out, and he did such a beautiful job. But no, I did it because I did the math. I didn't get mine out until my late 40s. And, you know, I've seen people go 40, 50 years. So I, you know, quickly did the math and thought, you know, I may be done. It's very important though. I don't use gold that often. Cost. I mean, cost is the big reason. So it's important though that patients and the public know about the Voco products. Specifically, what I'm talking about is Voco Admira Fusion. It's an Ormacer. It's an all ceramic restoration. It's a direct ceramic restoration. So we don't even use composites in our practice anymore. I mean, we'll call it a composite resin because that's, it's been how we've spoken, but we make the clear distinction that it's an Ormacer. It's BPA, BPS, and phthalate free. And it is wearing beautifully. It handles beautifully. It polishes. The restorations are beautiful. We were one of the first practices. It was released in January of 2016. We were one of the first practices to have it, and we've been using it now for just over 4 years, and the restorations are coming back looking wonderful.
Can you repeat the name of it, please?
Voco, VOCO, Admira, ADMIRA, Fusion, FUSION.
Okay.
There was a little bit of a learning curve in terms of managing and polishing. We used different points than we did when we were doing composites, and to get it to shine in some of the same way, the microfill composites, but to not have the BPA, BPS, and phthalates is huge. And, a really important thing is the sealants. Right? A lot of the sealants that are being done are heavily, they contain a fair amount of BPS. And actually, there were studies published with the American Dental Association that showed elevated urinary levels of BPA in children for 6 weeks following sealant placement. And, the pushback that you're going to get from standard dental community as well, it's just a little bit of BPA. But that's all it takes. Dan Lucchese, and one of my favorite times of the year is when we do we work together as a team at IFM to go through all the new research and the science and update all of our presentations. And one year, Dan just sent us an email and talked about how infinitesimal the amount of BPA is that is actually clinically significant. He's talking about a drop of water in the Pacific Ocean, or one car in a line of cars that goes around the equator 100 times. I mean, so when you get the pushback that it's just a little bit of BPA, all it takes is a little BPA to have significant effect. And, the parting phrase from both of these American Dental Association articles was, we're detecting the BPA in the urine of these children, and we don't know what the clinical effect of that is going to be. So Admira Fusion has a flowable. So we don't use sealants in our office. Patients, sealants, the easy sealant is to have your assistant or your hygienist, where they basically just treat the top of the tooth with an etch, and then they just paint the clear resin on. We don't do that. I'm the one that places sealants because I'll go in and I'll take a very tiny, thin little, we call it a fissurotomy burr. But we open up the grooves just a tiny little bit in order to flow this composite, the admira-fusion composite. See, we still say composite, but in order to flow the admira-fusion down into the grooves. So in my office, I mean, it's just, she could certainly do this, but she's not licensed to do this. You know, the dentists are the only practitioners that can make permanent adjustments to tooth structure. So I'm the one that does the sealants for children, and it's not conventional sealants. They're getting a very, very, very conservative composite or Ormesser restoration, a flowable Ormesser restoration. And that's the way the preventive restoration should be handled with children, in my opinion.
I know the Voco admira-fusion is, you said, it's a relatively new product. You started using it in 2016. How is the durability on it supposed to be? I know you can't say till it's been 10, 15 years or whatnot, but how would it compare to, say, because that was the big advantage with Mercury fillings, right? They lasted a lifetime. Right. How does that?
I think it's going to last longer than composite resin.
Okay. So
what I'm seeing after 4 years, they're looking like the day I placed them 4 years later. So I think they're going to. I think they're going to do better. Yeah.
So yeah, well, one thing I guess I wanted to clarify for the audience was, so you do see children in your practice, or you do not? Yeah.
I do. I see children. I mean, we joking. I had an adult practice for years, and was referring to a pedodontist in the area, but my parents were struggling to have him understand the BPA issue. And finally, they ganged up on me and prevailed upon me and said, so we see children whose parents, number one, they have to be able to behave like adults because, we don't have all the bells and whistles of a pediatric practice. And number two, their parents have to be patients of the practice.
Right.
So we'll see if it's part of a family. Yeah, we do. We do see kids. I love seeing the kids. I do. But yeah, and the kids we have are great. Just great. And, it makes a difference. I mean, we've had some children that had serious health issues, and attention to making sure that they don't have any fluoride, or they're not, and making sure that, but at the same time, we're evaluating their vitamin D levels. We're making sure that they're getting K2 in their diet. They're using MI paste, amorphous calcium phosphate, when they brush. We're taking x-rays only when we need to. Again, radiation is cumulative. And for kids in standard dental practices where they're taking x-rays every year, my children weren't radiated every year. I wouldn't, I treat the children in my practice the way I'd want to treat the way I treated my children. So, yeah.
Great.
I think you've answered all of our questions. Yeah. You spent quite a bit of time with us. We so appreciate it.
I am thrilled to do it. Anything to get the word out. I love the work you're doing. And Carol McMakin sometimes has FSM meetings in Henderson. I would love the opportunity to connect and meet. And
yeah, that'd be wonderful, actually. Yeah, and thank you for what you're doing. I mean, as far as bringing this to dentistry, I mean, I'm a big proponent of functional medicine. I love when I see it applied, and in my opinion, it should be applied to every square inch of our body. I think it can be, but I think it's we're still in those early stages where we're still figuring out how to do that. So, like I said, thank you for the work that you do.
Thank you. Well, and I think it's critical for dentistry. One of the points Dr. Glick made in his editorial was that if dentistry doesn't begin to think in these lines, I mean, he didn't use functional medicine, but he said unless we begin to find a way into the personalized medicine conversation, we are going to be relegated as a second-tier profession and lose our autonomy. And I have a daughter starting dental school in the summer, so I have a vested interest in making sure that the profession maintains the standards that it's always had.
I hope she follows you in your footsteps. So.
She will.
Or she will. Pediatric route. There's definitely a need for more.
She loves kids. She's thinking about orthodontics. She loves kids, actually. She does. She really loves kids. And she's already there. We had to counsel her you know, that if anybody asked her about Mercury, her response was to be, "You mean the planet?" until her foot's in that door, you know, where yeah, it's
avoid controversy.
no. She's well, they've grown up with it. Both of my kids have. Thank you for the work you're doing. Thank you. And if I can ever, you know, if you need an update or whatever, I'd be delighted.
Thank you so much. We really appreciate you taking the time.
All right.
All right. Take care. Bye-bye.
Bye.